Thank you all for joining us today. Today we are going to kickstart our learning collaborative of 4 sessions on incorporating peer support into substance use disorder treatment. And today we will be focusing on translating research to best practices. This is our disclaimer. This is a reminder that the content of this learning collaborative was 100% financed by the Health Resources and Services Administration and do not necessarily represent the official views of HRSA, HHS, or the U.S. government. The mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing primary care grantees and other health center grantees by providing training and technical assistance. And then here we just have a brief overview of our speakers and moderators for today. So with us, we have Dr. Kevin Lombardi, who is the Director of Research at the National Center for Health and Public Housing. And myself, I am Fide Pineda Sandoval. I am the Training and Technical Assistance Manager at NCHPH. And with us, we also have Jumoke Oladipo, who is the Health Communications and Research Analyst. Before we continue, also, we will first be going through our introductions and housekeeping items. We will provide a very brief PHPC overview. Then we're going to transfer the presentation to Dr. Kevin Lombardi to go over, and we will be going over some engagements today. And then if we have enough time, go over a Q&A and discussion session. Again, this is a reminder that all participants are muted upon entry. Please make sure that you engage in the chat. Raise your hand if you would like your line to also be unmuted. This meeting is also being recorded, and the slides and the recording link will be sent to you all via email after today's session. Again, this is something for your own review once we send the slides, but basically we just have some information here about public housing primary care health centers and public housing developments. This is just some demographic data based on 2023 UDS data. And also here we have public housing resident demographics data that was obtained from the HUD picture of subsidized adults. And now without further ado, I will pass it on to Dr. Kevin Lombardi, who will also provide a brief introduction about himself.
Hi, everyone. Dr. Kevin Lombardi, a medical doctor, an epidemiologist, and with training in internal medicine and interventional epidemiology. I'm the Director of Research at NCHPH, and today I'm going to be pulling you into a detailed clinical case to sort of set the stage for this whole learning collaborative. It's going to be interactive, it's going to be detailed, and we're going to learn a lot. So let's head on to the next slide and kind of go over the session format. Now, here's all the different things we are going to hit in this 4-session learning collaborative. We're going to go through the literature. We're going to look at the evidence of how peer support works, focus on the science, and look at those papers to see why it does work and how it impacts patients as on a measured basis. We're going to look at the epidemiology of the issue and understand just how prevalent OUD is and the importance of peer support within the therapy cocktail. We're going to be going over a lot of promising practices, and every session will have a detailed case study where we will follow a patient through a challenging clinical situation, and we will watch them utilize resources and discuss how they're doing that and how that affects our practice. Next slide, please. And we can pass that. Next slide as well. Okay, let's start. You guys excited? Jumoke, are you excited to start this?
I am.
This is Jumoke's first case study with us live on TV here. So let's see how she does. Fide's a veteran. Fide, are you excited?
Always excited.
Okay, let's do this. So we're going to start in the clinic. We are going to look through this patient and every piece of their story, and we're going to pick it apart. So we have Mrs. Nunez, 32-year-old woman who presents at the clinic to refill her medication. Health center. Mrs. Nunez, I always have a nice little collection of typos in there for you to find too. Mrs. Nunez is not enrolled as a patient at your clinic and has unknown insurance status. When providing an address at the front desk, she's noted to reside with her grandmother and 8-year-old daughter at a nearby public housing development. In the office, she's noted to be restless and sweating heavily. Okay, so we don't have much here, but let's pick it apart. Fide, grab me a detail here. Anything coming to the forefront of your mind when you think of this patient that just walked in?
Yeah, so definitely I'm noticing that she seems to be, I guess it's just her symptoms that appear to be visually, like that she appears to be restless and sweating heavily. So, that just kind of brings that to my attention, and then I start to wonder like what would be like the underlying reason why she needs to refill her medication. So
Yeah, so here's a follow-up for you. Let's say it's October and it's a solid 70 degrees in the clinic. She's still sitting there, restless and sweating heavily. It's not summer. Does that add some context for you?
yeah. Yeah.
Jamoke, what do you think? Same things or different things come into your mind with this patient so far?
I think the fact that she's not enrolled as a patient at this clinic, and then we don't know about her insurance as well.
Yeah, she just walked in. I mean, that happens, but we do mostly wellness visits, scheduled wellness visits.
Mm-hmm.
She just walked in. Peculiar, huh? All of these little details should be raising your suspicion that there may be a situation that you need to catch. Okay, we have a comment. Fide, could you do your thing?
Yes, of course. So we have Jennifer Yepes. If you could please unmute your line. You could also just participate verbally and let us know what are some of the things that you're also noticing about this patient.
Wait, first, can you introduce us, tell you who you are, who you serve, and where, please?
Can you hear me?
Yeah.
Okay. Hi, everyone. Good afternoon. My name is Jennifer Yepes. I'm the Assistant Director of Nursing for a Substance Abuse Program with Gotham Health Vanderbilt, which is part of NYCHHC. I am on Staten Island. And what stands out to me is, given how she's presenting, is the fact that she's asking for she's there for refills of her medication. Right? So we want to know what type of medications, when did she run out, and what her past medical history is. And that's all I wanted to share.
Keep going.
No, that's pretty much it. I want to know how,
So
how
that's the
long has
thing
she
that
been
popped up
without
in your
me?
mind.
Mm-hmm.
And let me throw you a horror story here. Just refill medication could mean, I'm behind and worried I'm gonna run out in a week, and it could mean that they haven't taken it for a month. That's a
Right,
big range.
exactly.
And those are those things that put your suspicion high. Yes, and 100%. Thank you. I have some nursing related stuff that we're going to get into soon, so I'm going to put you on call there. Fide, could we? I mean, that's what we see. That's all we know. What happens next? Okay. Okay, we have a nurse's assessment. Fide, could you read the slide for me, please?
Sure. So Mrs. Nunes undergoes a standard intake that includes a nurse's assessment, and the results are as follows. The blood pressure is 168/76, pulse is 90. Respiration is 22, and it seems to be shallow. For the posture, patient is noted to be hunched over and clutching their stomach. And for pain, the patient presents dull pain, crushing stomach pain, 4/10. Headache is 4/10, and the muscle aches is 5/10.
Okay. I'm going to break this down for a second, but I want to put Jennifer on the spot. I heard nursing in your job, so that's close enough for me. Could you tell me, give me a little bit of details of what you think here? What these vitals? What do you think? And correct my assumption there. Remind us what you do and what shows up in the forefront of your mind when you see these readings here.
Okay, uh-oh, no fair. I'm a target now, but I'm glad to
You are,
participate.
yes.
That's
Gotcha.
okay. So, what stands out is her elevated blood pressure, right? She also has some
Uh-huh.
shallow breathing. Her respiration is 22, not too high, but she could be, in some pain. So, she's hunched over. Clearly, she's in pain. So that's pretty much what stands out. We need to just assess a little bit more.
Mm-hmm. So
Mhm.
do these things, when you think of patient acuity, is this
Mhm.
going up or down in your mind as you're seeing these details?
Well, this is clearly something we can't ignore, right? So it's going up.
Mhm.
I mean, the vitals are not, they're stable, but there's a concern, something's going on. And so we have to see how stable the patient is and what else could be the underlying cause of how she's feeling.
100%. This
Mhm.
patient should go at the forefront of everyone's mind in the office right now,
Correct.
because these vitals are all concerning, and I'm going to pick them apart a little bit. Well, I don't know. We can pick on Fide first. Fide, any of these pop up for you in your mind?
Yeah, definitely the blood pressure seems to be very high. Not so trained in clinical readings, but I can just assume. So I think that also tells me that this patient is under a lot of stress.
Mm-hmm.
Also, the headache. She does have muscle aches. So, yeah, those are some of the things that just stand out to me.
You know, when I was in medical school, they did this class where they had us interpret art. And the guy who taught it said that looking at these vitals is a lot like looking at art. You see things in context and together and how they interact with each other because there's a tale to be told from every elevated blood pressure. And when I see all of these things, I'm starting to get suspicion of an acute medical issue. Now, I'm not going to say what I'm suspicious of, but anyone who's seen this patient knows this type of patient knows what they're seeing already. And when you see this patient walk into the clinic, all hands on deck and get ready to call emergency services if needed. That should already be in your mind. But let's progress. Let's see what happens. Okay, so we're here to the resident. The resident physician, the person that will be taking the appointment. When the patient does their intake, pops up on the computer in front of them for their 12:30. They click. See, there's no data about the patient. It kind of comes to the forefront of their mind because usually there's the records you can see. There's nothing there. The hospital and the medical center are in the same system, so they're able to check up the patient's hospital records. So these are things that really happen, and so this resident's doing that. Takes a look at the records, and here's what we find. So we have some diagnoses. The patient has a medical history that includes MDD, GAD, and opioid use disorder. Okay. Patient had a hospital admission for overdose in 2019, and she has been referred to outpatient OUD treatment, methadone, post-discharge in 2019. These are big pieces. Patient has a history of OUD and methadone treatment. So put that into context of what we're seeing unfolding in front of us. Next slide, please. So we take a closer look. What do we find? So the patient was admitted from the emergency department, and this was in 2019. We're looking at that record of that hospital visit. She came into the emergency department and had acute severe withdrawal symptoms. And this was 12 hours after stopping heroin use. These are when, for short-acting opioids like heroin, that's when the withdrawal symptoms start to get really nasty. They get very visceral, extremely uncomfortable, and you see those patients in the emergency department. They're very common admissions, and they often end up having to be admitted to the hospital for medical complaints like severe tachycardia, stuff like that. These patients need a lot of support. You can't just simply send them home on methadone most of the time. In the ED, she's treated with patients with sort of the standard cocktail for these patients, and she's admitted because her heart rate is so high and concerns for cardiac arrhythmia. Very often, when you look at these patients' EKGs, their heart rhythm is concerning. You can't quite tell, but you want a cardiologist to see it. That's another reason they're often admitted. So she went to the hospital, got all that taken care of, and she was discharged in 48 hours. That's what happened in 2019. Okay, let's throw this to the audience, folks. We're going to start with you, Jamoke, and anyone else, put your hands up. So you see this patient, they walk through the door, they're not feeling well, and you see this in front of you that happened a couple of years ago. What's coming to the forefront of your mind? You're this student or this resident looking at this record.
Well, I knew her blood pressure and her pulse was very high. So if she had tachycardia before, I would be questioning whether she's currently going through the same symptoms.
Mm-hmm. This is the first thing that would come to my mind is this a withdrawal?
Mm-hmm.
And I'll ask the group, what about this patient's physical symptoms screamed withdrawal for you? And I'll ask, go back one so we can take a look at this again. The physical symptoms. One more. For those of you who are in the know, who treat patients, are there any physical symptoms or signs about this patient, how they presented, that now that you know, that you're thinking, that confirms my suspicion? And I'll pick Jennifer, and then I'm going to pick someone from another one from the audience. Jennifer, what are you thinking now?
So I won't take all the answers, but I can say that some muscle aches. I have more to that answer, but I'll give everyone else a chance. But muscle aches.
No,
are
I want to
definitely-
poke at you there. With that, specifically with the muscle aches, is that
Mhm.
something that you've either seen or noticed that these patients experience? Because you said it confirms your suspicion, right?
Right. So muscle aches, yes. When a patient is going through withdrawal, they have muscle aches is one of the symptoms that we use to calculate what scale. So we use a CAL scale, right? It's the clinical opioid withdrawal scale. So that's one of the symptoms that we would check for and rate it to see what level
Have
of
you seen
withdrawal
patients
they're on.
experience this? Have you seen patients in front of you experience this before?
Yes.
What does it look like?
They pretty much look restless, right? They can't sit still. They're clearly in somewhat of a distress because they're going through the withdrawal.
So you can see it, really.
Right.
Like once you have that suspicion and you look back in the patient, and I'm trying to draw the artistic part of this, right?
Mhm. Mhm.
You see that patient and you have this suspicion, you know what you're dealing with. Of course, you'll have a differential diagnosis. Perhaps it's something else. We'll do drug screen, figure out all of these things. But
Right.
that's something that you viscerally know when you see the patient. And I'll tell you, from seeing very, very severe withdrawals, the worst of the worst, it hurts.
Mhm.
Some of the worst pain I have ever seen human beings be in is in a severe opioid withdrawal.
Right.
And
And of course, I'm sorry, go ahead.
please, no, please.
No, I was going to say, of course, given the known medical history, that helps you, rule out other things. You always have to do a thorough assessment and not just jump to conclusion, but knowing the history definitely does help.
Mm. I'll tell you something that comes to mind through what I've seen and what I've done is with these sorts of patients, the pain they're experiencing is unimaginable. being able to recognize it quickly and safely and get them to treatment and diagnosis quickly takes a long time off of that suffering for them, a long time after suffering. So knowing and being able to pick these things out quick is very important. So I'll say from the rest of the group, anyone see any other vital signs or symptoms that that catch them when they read this, and now that they know that that patient's possibly experiencing that, say, oh, aha, that makes a lot more sense. Fide, do you think?
All right. Natasha Sullivan, would you like to provide any feedback regarding this patient?
Latasha, even if you aren't a clinical person, is there anything that pokes out to you when you see this patient now and you think, that means I'm giving it to you, Fide.
Yeah.
What are your moments?
Like what stands out for me also?
Now that you know that this patient has
Mhm.
experienced a withdrawal and a hospital admission in the past, and you look back at this, what do you think? Because I'm getting somewhere with this, I promise.
Yeah, no, I feel like she is definitely having the same withdrawals like all over again. But it's getting worse. So she's possibly becoming more dependent on
Well,
the opioid.
I'll tell you what comes to the forefront of my mind, because you got half of it. And the thing is, everyone experiences a withdrawal a little differently. Any medical complaint. Some folks, it's going to be all in the muscle aches. Some, it's all nausea. And people describe symptoms differently. So it's not always clear. They don't give you the thing like it looks in the textbook or in the case study. They say these are human beings communicating things. So it ranges significantly from one person to another um, uh, what they're actually experiencing. So when you look at that clinical history and you've got a hospital note, which is like, I can't tell you how many times I figured this out because I just did the same thing, okay, look at their hospital notes. Oh, yeah, they had the exact same symptoms last time. It's going to be like that. And then you'll see that patient and snap, and you'll know exactly what to do. Fide, we had a comment. Was there some context or an answer for you?
Yes, yeah, definitely. So we did have a comment from Darian. He said that his mic isn't working and that he's also not clinical, but he wanted to say that what stood out to him was being hunched over and the different symptoms such as headaches and weaknesses. Um, I am so sorry. But yes,
100%.
yeah, and
And
you can,
I'll tell you the difference between the before and the after there. Those are very non-specific symptoms when you don't have a context. When you know that the patient has experienced those in the context with withdrawal, you know. And let me tell you, this isn't just important for clinical people. If you're working with these patients, you will be if you're working with these patients one-on-one, they are really always at risk for withdrawal. And the CHWs, the peer support folks and so forth, are at the front line of identification for these medical emergencies when we happen. So that's why I'm really beating on these details, because knowing them is the difference between life or death sometimes when these situations happen, and they do happen. Fide, sorry, I interrupted you there.
Oh, no, no worries. I just wanted to remind everyone who is in the line that even if you're not able to participate verbally, you can also just enter any responses in the chat and we can always read them out loud.
Okay, next slide. Oh, two more. Go to where we were. I think we were next one after that. Okay. Okay, so we look closer at the record. Jamoke, read it for me. Same hospital record, but we're looking at the details.
Okay, so the patient was admitted from the emergency department after presenting for acute severe opioid withdrawal symptoms post 12 hours from heroin use cessation. In the admission
Okay.
department, she was treated with
You need to go through the medications, but that's the cocktail. Yeah.
Mhm. And then she was admitted to the hospital for severe tachycardia and concerns for cardiac arrhythmia. And she was
Okay.
prescribed methadone, and the dose adjustment was performed in the hospital, and she was discharged 48 hours to outpatient after that. 48 hours after that to outpatient.
So Jamoke, this is exactly how it would be in a medical record. That's
Yeah.
exactly how it would be written. Is that in English to you? Because I'm thinking of how I would read that before I went to medical school and what it would mean to you. Does that seem very direct in explaining what the patient went through?
I understand the acute withdrawal symptoms,
Mm-hmm.
and then it's a bunch of medication, and then she was released 48 hours later.
It's basically in a different language, right?
Yeah.
And that's the tough stuff with this. When you're dealing with folks that experience these medical issues, you're going to, at a certain point, going to need to look at these records for one reason or another. If you're not, you're missing opportunities. And being able to read this stuff is tough because it's basically in Latin here. So let's translate this and look what this actually means. And this is exactly how it will be on a medical record. And I can't tell you how many times I've had medical issues that have come back to the ER because the way that I write medical records is for the insurance company. It's not for the community health worker to follow. So that's often a huge issue, and it helps to get exposure to this stuff. So let's break it down and see what this means. So basically, one, patient went to the ED because they're having acute withdrawal. Acute withdrawal for heroin, 6 to 12 hours after use, that's when you're going to see the symptoms get really bad. Makes sense. The cocktail, she receives things for her symptoms, her nausea, Zofran's for nausea, and diarrhea. This is all symptomatic treatment. Okay. Okay, and then she has to go to the hospital. Patients go into the hospital when their situation is very acute. If that person went to the ED and then needed to go in the hospital, that means that was severe. And she was started on methadone. That's one of the medications that people take for long-term treatment, chronic treatment. So we know that. Okay, this tells us an immense amount of this patient. We have a patient that comes into our clinic. She's experiencing possibly acute withdrawal symptoms, and we know from the record that she has withdrawal issues, and her symptoms are pretty serious. Next slide. We do a physical exam and see that she's anxious. She's got really bad muscle aches. When you touch or move her body, it hurts. Her abdomen hurts everywhere you touch her, and the pain is now 7 out of 10. It's getting worse. It was 4 out of 10 when she came in. Now it's 7 out of 10. Looking at her vitals, they've gotten worse too. BP's 200 over 80, 20 points. Heart rate's now over 100, and she's got EKG findings as well. And mild ST depression, T wave flattening, benign signs, but still, I don't understand them in this context, and this is very alarming. If this patient walks into a clinic, into a primary care clinic with these symptoms and with these history, what should you immediately be thinking of what the next step is? And I'll ask the group, does anything come? And it's a simple step. Anyone, does something come to mind? Next step. And if not, this is yours, Fide.
All right. How about Stephanie White?
Oh, we got we got it. It just came up. Jennifer, you know we'll just pull you on the panel. But Stephanie, you're gonna do it for us. You're gonna do it for us.
I hope she's able to speak. I guess not. What about Rosie Tavares?
It's only so much coffee I could drink here, folks. Okay, Jennifer, you're jumping in. You're on the panel. Let's hear. Give us the 411. What's the next step?
All right, I guess I'll go. So the patient's here. We're going to call the doctor. We're going to go ahead and call the doctor and just get ready to call 911. Bring in
100%.
Yeah.
Yes. That
Absolutely.
patient needs to go to the
Mhm.
hospital. It's getting worse. When
Right.
these are happening in front of you and you can see a patient decompensating, do not hesitate. This is a primary care office. The patient needs to be given naloxone. She needs to be get pre-hospital treatment and to the ED. And I say that because let me tell you, when someone's decompensating in front of you and they're going from provider to provider, they start at the front desk, then they go to the nurse, then they do this. No one's in front of them for 10, 15 minutes. They may not see the decompensating happening. So when you see a patient that looks like this, those alarm bells should go off because this is a very common situation. That decompensating happens in the clinic. It happens in peer support meetings. It happens in CHW coaching sessions. And just knowing that if a patient is experiencing these things happening quickly, that should always put your mind to 911. These are life-threatening medical emergencies, and they can go from bad to worse so quick. And it's very hard to predict. So you should have a very low threshold for calling emergency services with folks like this, who are experiencing symptoms like this. Okay, let's get going.
All right.
Oh, and next slide. Yeah, okay. Okay, so we're still in the clinic. Here's what we get. Mrs. Nunez reports that she has not utilized opioids, but stopped methadone treating on her own accord 12 hours ago. She's noted to experiencing symptoms concerning for acute opioid withdrawal. She's transported to the hospital via ambulance. Okay. Next slide, please. This is for everyone. What did we miss? There's some things we could have done quicker here. There was some way the team could have talked more effectively. There's some information we could have gathered that we did not. And there's some tests we could have done. And I don't know, there's some ways we could have treated this patient that was different. So, Fide, do you think? And if we don't get anyone this time, I'm just going to start talking about my fig trees. So be careful. Fide, I think we got one. The fig trees scared them.
All right, so we received a All right. So we received a response from Jacob, and he said when she came in, she was sweating profusely. Given the weather, that tells me that something is happening and the situation is urgent.
Yeah, so what I'll ask is, Jacob, please introduce yourself, tell us who you serve, and I'm going to ask you, did we do that quick enough? How would you have done it?
I mean, so I will say that I had some people walk into my office, so I missed some parts of it. But I remember thinking when you initially brought up the case study, the sweating automatically signals to me that, something's going on, especially when you said that it's in the fall. Like the only reason somebody's profusely sweating is if they have something going on. I think that I don't know how long it took. Like I said, I had somebody come into my office, but from that initial getting in to getting back to being seen, I think probably could have gone probably a bit smoother. Oftentimes with people with SUD, they get overlooked in the clinic. And I think that's really easy to do. So, yeah. Oh, and I
Nailed it.
the healthcare connection in Cincinnati, Ohio. I feel like everybody else is from New York. Don't worry, I used to live in New York. So
I'll ask you, I'll tell you that you nailed it there. This was slow. It's October, it's 70 degrees out. I made that point. These folks should have grabbed this earlier. If you see someone profusely sweating in your wellness clinic, you send a nurse out there to talk to them. But let me tell you, I cannot tell you how many folks that I have personally seen go into severe withdrawal in waiting rooms, ER waiting rooms. They're busy, you know, like it's difficult to see this stuff, but keeping your level of awareness high, and like Jennifer says, faster assessment from the nurse, 100%. So okay, we this is in the nurse realm here. So and I'll tell you, stay on the line if you don't mind, Jake, because I want to throw it to you in a second. But nurse perspective here. The nurse was, the whole chain missed this one, including the nurse. But what do you think about the nurse here? What would you have done different?
Is that question for me? Oh, taking the patient into the isolation room and really giving them the time to do a thorough assessment of what they've taken, when was the last opioid they were taking, what type of MAT have they been using, when was the last dose. We would have caught it faster. She would have said, the last dose I stopped cold turkey, last dose was 12 hours ago, and just called the provider and called 911 sooner.
Yes. And I'll tell you, we manage these patients through interdisciplinary conversations. Physicians and nurses are taught differently. Nurses are taught using a patient-centered model, and trust and believe when you're working together with your nurse, they're going to catch this stuff before you do, just because of how they think about this stuff. 100%. If your nurse is doing the assessment, they should be trained, and they should be able to see that this patient is acute immediately. The person at the front desk, they should understand it too and be able to tell the nurse to get that. That's when we missed it first. But then the nurse, she just sent the person alone to the patient room to wait another 15 minutes for the doctor. That patient could have died in that room. Do you have something to add to that, Jennifer?
That was a mistake. Sorry, I was trying to put a thumbs down for that nurse. Sorry about that.
Yeah, we like, this may not seem like it, but our team, all of us, almost killed this patient today, just because of something like that. And let me tell you, a common mistake. Done it, been there. And I want to throw something back to Jake, because you said that these patients aren't really seen or caught in the when they're you mentioned the physical complaints, but people miss it. Do you have any more info or thoughts about that? Because I couldn't agree more.
I think more importantly that patients with substance use disorder are often just disregarded unless they are in some kind of actual acute distress, like having an overdose in front of you. I think oftentimes they just are neglected and left to have a situation as our case study did, as the patient did, which is, you're going to wait, you're not my priority right now. And I think maybe that's more importantly what happens in so many places, even those that provide, that say they are competent and provide MAT treatment and services.
I'm going to thank you for that. And I want to throw that to Jamoke, because that's some social context that's very valuable to this. If you're that person who's experiencing a substance abuse issue and experiencing that stigma, how does that make you feel? Let's try to understand how these folks feel. They come for care and they're treated like that. How does that feel?
Like you're less of a priority, so you're less likely to seek care later on.
Can we think of any, yes, 100%. It's dehumanizing too. It's a terrible, terrible feeling to be in pain like this. And it's even worse to be ignored. And and I can tell you, I'm guilty of it. The ED is busy and crazy. And let me tell you, when I trained in DC and in an urban hospital in medical school, and when I did my rotations there, back to back, the whole side of the hospital was withdrawals on Saturday, 10 or 12 of them, one physician seeing all of them. These folks often get ignored in those situations, and it's very difficult to pick this stuff up when you're seeing these folks all the time. And it's not just because there's a lot of them, because at times we dehumanize these individuals because of what they're experiencing. Often they're dealing with other social issues. They're from disadvantaged groups. There are all of these biases that trust and believe the providers have them just like any normal person has them. And seeing the patients over and over again, it has a sort of amount of battle fatigue. You see enough people die of this stuff, you start to really hate it, and it makes some people angry. If you're seeing these patients, you need to be talking to colleagues about these feelings, because let's be honest, with opioid use disorder, it's a war. We're on the front lines, and you're going to feel a lot of emotions when you're dealing with it. And often that leads to dehumanization. It's something that just happens. So we need to talk about those experiences and do stuff like this, or we don't have that reminder. Some people need it more than others, but I know that I do. Because when you're seeing the 30th of an individual like this, and people are telling you, your attendings are telling you, you're hearing whispers, or they're just here for a dilaudid dose, or they're just here to get their fix. This is the things that people really say. It starts to enforce a bias. And that's at every healthcare center in the country. That bias is very difficult not to just naturally accumulate unless we stop ourselves and think about what those patients are experiencing. So I'll leave that and asked if anyone else in the group. Thank you for your participation, Jake. We'll be asking you again to jump in. But I would love to see if there's any other voices here. So what do we miss?
Okay, so there are no other responses here in the chat.
We can go then, because we're actually close on time here. I got yapping again. So we're gonna pick up the pace here a little bit. Let's go into the ED. So ambulance to the ED. Mrs. Nunez is treated for mild opioid withdrawal syndromes. IV fluids, Suboxone, clonidine, Zofran. It's the cocktail, physical symptoms, and so forth. Zofran is the nausea medication, right? Loperamide's for diarrhea. Clonidine is for those physical symptoms. Suboxone is to treat the underlying disorder and for safety. So she's also treated with a maintenance dose of methadone. She has an established record at a methadone clinic. We give her absolutely give her that maintenance dose. We ask her some questions, and she tells us. One, she had been compliant with her maintenance methadone therapy until yesterday. That works with the timeline, right? She discontinued use because she felt she did not need it, and she had traded one addiction for the other. She's been on this stuff since 2019. People get sick of it. She also complained of weight gain. Common complaints. If you're on methadone's free, she didn't use any opioids. She just stopped using her therapy. She thought she didn't need it anymore. This is a common story. Methadone clinics take time. You got to show up for your medication. You got to go for appointments. It is time consuming. It is difficult. If you're dealing with depression and social issues at the same time, whoa, it's hard to stick to it. People fall off of that bus all the time, and you got to understand the challenges that lead to that. Patient education, we're getting there. We're getting there. Did you read my case study, Jennifer? But anyway, just humanizing the patient a little bit there and telling you they stopped using those medications. And I'm doing that because I have personally, raise your hand if you've been angered by a patient that stopped taking their methadone. Yeah, it gets you angry when you see that. It's a strong emotion. You see a patient that's done great and then they stop taking the methadone and you're like, again, I see this story. It's very frustrating. But you should be frustrated with opioid use disorder, not with the patients, because it's difficult. Just a reminder, because it's hard not to get frustrated, because these are challenging. This is a challenge condition that makes people's lives challenging. And guess what? We're in it together. So if you haven't experienced those frustrations, you will. And just know that they're natural, and it's part of the battle that we're in. Opioid use disorder is a difficult condition to go through. Next slide. Okay. She's interested in continuing methadone therapy. Good. And let me tell you, you only need to go through a couple of these withdrawals. Like, these patients are often like, yes, yes, back on methadone. They don't want to experience that again. They were not expecting that. She's referred to outpatient therapy. And here's where we get to Jennifer. She said this patient needs patient education. Well, this patient is referred to a community health worker. Okay. For follow-up, that's standard social services in the system, as it is in many of yours. Next slide. Okay, you guys know Mrs. Nunez at this point. What type of social support do you think she needs now? We're about to know, but what do you think she needs? And we'll go hands, and then it's Jamoke's. Stephanie, why would you think that this patient needs peer support? That sounds expensive. Sounds like a lot of trouble. Why would we think that she'd benefit from it? Fide, do you think? Fide's going to get you up here.
I'm trying. No, but Stephanie did do a follow-up. She mentioned someone who's experienced the same thing as her. It matters, no stigma attached with the peer support response. Mhm.
Stephanie, you mentioned a big word there. You have anything to say about stigma in a patient like Mrs. Nunez? Fide, you're going to be our microphone for this. Oh, excuse me.
No, she said she doesn't have a mic. So yeah, that's fine. Just take your time typing your response.
No worries. If you got something else to add, Stephanie, add it. But I'm going to say that we're about to get into the story, and I want you to keep that in the back of your mind, where peer support would potentially help this person. Absolutely. This is for someone who's experiencing stigma, and what better way than to involve yourself in peer support and to receive that emotional support and the training associated. Is there anything else that pops up? Jamoke.
Sorry. Go ahead. Yeah, Jamoke.
Oh,
Read,
I can read
read
stuff.
that for me, and then I've got a question for you, Jamoke.
Yep, she says she will most likely be more open and honest with someone she can relate to.
100%. And I'll follow up. One question for you, Stephanie. Type this in for us. Okay. Peer support. Say someone doesn't want to do it. Who are they more likely to listen to? Are they likely to listen to me, the doctor, in the emergency room, saying, "Hey, here's another medication. You need peer support. Here's a resource." Or are they more likely to listen to a community health worker who tells them about the program? Who are they more likely to listen to, Stephanie? Just make a guess. 100%. 100%. They don't listen to us. And I'll tell you why. Because when you're in an ER or you're in a in a clinic, let me tell you, I check the blood pressure after the nurses do, and it's always higher when I do it. You know why? Because people are stressed out in front of doctors. Doctors give bad news to them. They may have bad experiences with doctors. There's a power differential there that makes the communications difficult, because it sometimes makes folks stressed, especially in certain disadvantaged groups. And a guy like me can be trying his best, but when I'm in the ER, I'm moving. And I'm moving. And that can be intimidating to folks. So when they're sitting down with the CHW, that might be someone from their community, but it's someone who has time for them, and it's someone who understands the resources a lot more than it works. You know what I know about peer support before I prepared for this? It works. But the folks that actually administer it and are closer to it in the pipeline are going to be able to make a better argument. And nurses there too. They are closer to the patient. It's a proximity thing. So let's Jamoke, what do we don't have? We don't have something here that would tell us what kind of things this patient would need. What did we not do?
Screening for.
We screwed up
for
here
the-
too. Yeah, this person should have been SDOH screened in the clinic. Well, at least in the ER. The clinic was kind of acute. I mean, I can understand they didn't get it right there. But in the ER, she should have done that. This is a medical system that has this resources. We know. Why are they not screening? That mistake is very common. I've done it. And you've got to pay attention to miss those gaps. Look at the patient flow and see where you're doing your SDOH screeners. The sooner the better, because the sooner the better you get them to CHWs, the sooner you're going to help them with those issues that need to be addressed. Or trust and believe you will be seeing them again in your ER. There are financial consequences for that. Those 24 hours and 48-hour bounce backs. You help your system by treating these patients more effectively, and we can all get better. Next slide. Next slide, please.
I did want to mention that Jake also mentioned that she could use an exit ramp from her provider.
100%.
Yeah.
Often missed and very important. Next slide. Okay, we're gonna blaze through this last part and get to the sinker here at the end of novella. Mrs. Nunez is seen by her CHW after her ED visit. 2 weeks after. Oh, wait, 1 week after. She's compliant with her methadone treatment. Good. Good. She should receive a high five for that. She's abstinent of opioid use, and she's experienced a full resolution of symptoms. Good. We do a screener. Let's see what it says. And I'm going to read through this. Let's go. Next slide. SDOH screener. No food insecurity. The patient's housed. No issues with utility. Okay, good. Transportation's issue. This patient is having trouble finding transportation and daycare. Next slide. Patient's unemployed without regular income and is interested in working. Next slide. No issues with, she doesn't want more education or job training. Oh, something there stick out, Jumoke?
Yeah, concerned with someone in your home using drugs and alcohol. So if it's not her, it's someone else.
Bam! Is that can we trust it? Someone throw it in the chat. Is this a problem for a patient who's a former opioid user, is on methadone, and she's exposed to someone who uses again? Is that an issue? I got to see the chat light up. Yes! Bam, bam, yes. And this is often a source of stress that can lead to things like not taking your methadone. She said she felt addicted again, like she was swapping one for addiction for at home. Well, if there's someone at home that's newly addicted, maybe she's thinking about that in that way because of that. These things all connect. Next slide. 100%, very common cause of relapse. 100%. 100%. So we look at the issues here. Father's daughter recently relapsed. Heroin. These are details follow-ups from the SDOH questionnaire. She's unemployed and dependent on her grandmother and child support for income. She would like to work but struggles to find childcare, and she reports feelings of social isolation and worsening symptoms of depression. She lacks regular transportation. Okay, so what about this patient screams? Back first. What about this patient screams, I would be served well by peer support? Someone.
Oh, there's nothing currently in the chat. The social isolation part.
I want to say,
Who said it?
Yeah. Her daughter's father recently relapsed. Maybe that's something that the peer support can talk about, their life experiences and stuff.
100%. Any others? Just mic off and go ahead. Interrupt us, please.
Jacob mentioned social isolation.
100%. Is opioid use disorder isolating? Ask yourselves. So much. So much. Often folks need to leave a whole social network just not to be exposed to stuff anymore. That's very isolating. You feel isolated in your own community. And what does isolation lead to? What does isolation often lead to? It can lead to relapse. And it makes a lot of sense when you think about it. Next slide. So, what does Mrs. Nunez get? Peer support is a label that covers a lot of things, and everyone covers different things. But these are the things that really mattered to her. And I'll tell you why. One-on-one group membership with a senior group member. This is a younger woman. She's 32 years old. She has had a long and difficult life. She's got an 8-year-old. She's receiving child support. It doesn't seem like the father is at home. Who knows how involved they are? She lives with her grandmother. She's exposed to drugs but not relapsing. Wow. Seems like, one, this is a person that could be a mentor someday and that would be a very good and appropriate mentee right now, too. What's that going to provide? It's going to provide roads to recovery, roads to success, and culturally appropriate. And we don't know what culture she's from, but whatever it is, if she's talking to someone who's like her, there's a level of communication and understanding she's going to be able to get that she can't get otherwise. Speaking to someone from her community, from her neighborhood, that is a superpower for recovery. 2, assistance with care coordination, public health education. When you are talking to folks in a peer support group, that is a information sharing superhighway. Folks learn how to coordinate their care. They know how to get their insurance, be on top of their methadone treatment. This stuff puts them more in control of their lives and less likely to end up in the emergency department. Crisis support. Every person should have a personal relapse plan who's in these. And where do you make them? You make them at peer support. Coping strategies are not something you don't just say, oh, I'm going to sit down and cope for a little while. You learn specific things. And yes, Fide, I'm finishing up, I promise. And next slide. Okay, let's open it up. What are some benefits that someone like Mrs. Nunez receives that I haven't mentioned? Let's open it up. How does she benefit? Her, knowing her, what is she benefiting from this? Or why would she show up? They do need to show up.
She gets a chance, like an open room, to discuss how she's feeling, to discuss her care. She gets that opportunity to discuss, how she's been doing.
Sounds like it feels great. For these patients, it can be like weight off their shoulders. Fide, could you read the comment, please?
Yeah. Having a support system to make sure she doesn't relapse.
This patient has already confirmed they're experiencing social isolation. Removing that is one of the best things you can do for their overall health, including their ability to sustain recovery. I can't emphasize that enough. We are intensely social beings, and OUD can be isolating. And when you're in a community of people who you feel are like you, wow, is that going to feel great? It feels soothing to individuals. That's how they have described it to me. Any others before we wrap up?
And an understanding of what she is going through from people who have experienced it.
Yes.
Yeah.
When I think of that, I think for individuals, there's no roadmap for this, right? This is a very visceral experience. And the only folks who can really understand that are the folks that have been through it corporeally. It's like me explaining to you what childbirth is like. I have no idea. I can tell you what the textbook said, but that's it. When you're an OUD patient and being able to talk to someone who's experienced that again, that as well, not only does it destigmatize it, but that's very real because that's someone who's experienced that visceral feeling, has that visceral understanding, and that's valuable to folks because that helps them navigate things. It makes things less scary when they happen. It makes them feel more in control. That's what I think about that. Fide, I'll stop.
All right, thank you. Thank you everyone today for participating and being part of the engagements. So in the slides, you will see that there is some additional information, including some SEOH screening information and promising practices, something that you guys could review on your own. And this is just a reminder to please complete our post-evaluation survey. And in there, you can also let us know what are some of the things that you would like to also see in the next upcoming sessions. And we'll try to incorporate that in there.
Oh, Fide, just very briefly. Next
Mhm.
week, we'll be looking at the research directly and doing a smaller case study. So it'll be about half didactic and half discussion. I'm muting now.
Thank you, Kevin. Yeah, I was gonna ask you to provide everybody like just an advancement from next week. So, and that's about it. So we'll see you next week on Monday at 2 p.m. And please, you can also use the same registration link that you used to join today. And thank you all, and we'll see you soon. Have a great day.